So she is going to speak on presbyopia correcting IOLs, multifocal IOLs, and extended range vision IOLs.
Good afternoon, everyone. I'll be talking about presbyopia correcting IOLs. I thank the chairperson for giving me this opportunity. British ophthalmologist Sir Harold Ridley is credited with the first implantation of intraocular IOLs. IOLs have come a long way since then. Presbyopia is a condition in which the lens loses its accommodative capability. Cataract surgery leads to an absolute state of presbyopia. Presbyopia correcting IOLs are a treatment option for patients who are not candidates for laser refractive surgery and who do not want to rely on spectacles for near work. Now, presbyopia correcting IOLs can be either the accommodative IOLs or the simultaneous vision lenses. Simultaneous vision lenses can be either the multifocal IOLs or the extended range vision IOLs, which can include the EDOF lenses or the plus monofocal. The multifocal IOLs have two or more distinct focal points corresponding to distance near and intermediate points, and the light is divided between these multiple focal points. They are classified based on their optic design into zonal refractive, diffractive with or without apodization, or based on their focality as bifocal, trifocal, or quadrifocal. Zonal refractive IOLs have multiple zones with different foci. Diffractive IOLs are based on diffraction of light and constructive or destructive interference to create these multiple focal points. An apodized diffractive IOL has diffractive gratings with decrease in height from the center to the periphery, giving rise to a smooth transition of power. This table shows three different multifocal IOLs. Here we can see that the PanOptix has a intermediate add of plus 2.17 corresponding to intermediate viewing distance of 60 centimeters, whereas it is 80 centimeters for the other two. The optic design of apodized diffractive lens in fine vision makes it less tolerant to tilt and decentration. The asphericity has a bearing on the post-refractive surgery patients, and hydrophobic lens material leads to lower rates of posterior capsule opacification. The clinical tools that we use to evaluate these lenses could be the visual acuity, that is the uncorrected distance visual acuity and the corrected distance visual acuity, the uncorrected intermediate visual acuity, the distance corrected intermediate visual acuity, and the uncorrected and corrected near visual acuity. The defocus curves, contrast sensitivity, patient-reported outcomes like spectacle independence, and the photic phenomenon. Multifocal IOLs provide good patient satisfaction and spectacle independence for far, intermediate, and near, but by virtue of their design, they have two prominent drawbacks. The light allocation is divided between distance, intermediate, and near points, and the second drawback is because of the discrete focal points, they give rise to multiple unfocused images creating the halos. Now, in post-refractive surgery patients, the key points to keep in mind is that in patients with irregular astigmatism or decentered ablations, they are poor candidates for multifocal IOLs. And intraocular lenses with a negative spherical aberration reduce the positive corneal spherical aberration induced by myopic LASIK, and intraocular lenses with zero spherical aberration match the corneal aberration of the hyperopic patient. Now, contraindications. By virtue of the light splitting technology, these lenses hamper the contrast sensitivity in mesopic conditions and also hamper the perimetric testing in glaucoma patients. Similarly, in significant macular pathologies, they are contraindicated. These IOLs are less tolerant to tilt, decentration, and changes in pupil size, and post-LASIK patients with decentered ablation and irregular astigmatism are not good candidates. The ideal candidate for a multifocal IOL is a person with easygoing personality with realistic expectation who desire spectacle freedom for near work and do not have heavy dependence on mesopic or low contrast sensitivity settings. The main limitation of multifocal IOLs are in terms of the dysphotopsia, which are the glare, which is more due to the diffractive design as diffraction leads to scattering of light. Dysphotopsia can be positive in the form of flashes or negative in the form of shadows in the temporal field, which is increased by decentration of the IOL, small optic or large pupil. Halos are the ghost images due to the multiple unfocused images in the multifocal IOLs. The next in class of IOLs is the extended depth of focus IOLs. The optical principle is that they have an elongated focal point covering the far and intermediate ranges, unlike the sharp and distinct focal points of the multifocal IOLs. And due to their elongated focal point, the problem of unfocused multiple images and halos are reduced. The true EDOF IOL do not have zonal refractive or diffractive optics, and therefore the incident light reaches the eye wholly, giving rise to a better contrast sensitivity profile. The trade-off is a slight compromise in the sharpness or crispness of the image. A defocus curve is a graph plotted between the defocus over the distance correction with the visual acuity. As we can see that the monofocal IOL has a single hump, the bifocal IOL have two humps corresponding to the two discrete focal points, and the EDOF IOL has a smoother curve with a higher landing zone. Technis Symphony was the first EDOF IOL available, but it was later classified as a hybrid IOL on basis of its posterior diffractive surface and asphericity of the anterior surface. The types of EDOF IOLs available are based on either the pinhole effect, the spherical aberration, wavefront shaping, and the diffractive methods. The pinhole effect IOLs have a small aperture, which increase the depth of focus. The spherical aberration IOLs modulate the spherical asphericity of the IOL. The diffractive IOL decrease the near add to give a continuous range of vision from distance to intermediate, and the wavefront shaping optics are the latest in the class, which do not waste the light energy and give a quality of vision which is comparable to the monofocal IOLs. So the EDOF IOL criteria as defined by the American Task Force, that it should give a better depth of focus compared to a standard monofocal, and it should give a distant corrected intermediate visual acuity at 66 centimeter of at least 0.2 logmar. Comparison of multifocal IOL to the EDOF IOL, we can see that between the viewing distances of 40 to 25 centimeters, the visual acuity is better for trifocals compared to the EDOF. Trifocal IOLs are 10% more likely to give spectacle independence, but they cause more halos. Neuroadaptation leads to better outcomes after 3 to 6 months. And on the other hand, the EDOF IOL gives significantly better uncorrected. The Exten class, and they do not meet the full criteria of EDOF, but they improve the intermediate vision. So for choosing the right IOL, if the patient has dependence on intermediate vision, then trifocal or EDOF would be the better choices. For patients needing near activity, for low contrast activity plus monofocal IOLs, and for glaucoma advanced ARMD, monofocal IOLs would be a better option. Thank you.
So which IOL do you suggest for a surgeon like me, ophthalmic surgeon? Which IOL do you suggest?
She wants to keep you awake.
No, but the question is, what is your experience of Rayner? How long have you followed up, and what is the results after 6 months, 8 months, 10 months, something like that?